everyone and welcome back. So in this video we will discuss the topic PDA, that is Patent Ductus Arteriosus. So we are having a scenario that there is 2 days old preterm baby who has machinery murmur and continues heart below the left clavicle, and he shows no signs of congestive heart failure. So there is only the sign of heart machinery murmur. So what are the causes of murmurs and how will you confirm the diagnosis, and what is the medical treatment? Mention the name, the dose, the duration, and proper time to start therapy. Another scenario is that there is 4 years old boy presented with history of failure to thrive and recurrent chest infections. Parent also told that he is very tired and often has shortness of breath during playing. On examination, his weight is below third centile and height is 10th centile for his age. He is pale, but there is no cyanosis and clubbing. He has bounding pulses and wide pulse pressure. On chest examination, he has bilateral equal injury, and this is also a continuous murmur. Okay, so in this scenario, it is obvious that the clinical features of patent ductus arteriosus are machinery murmur. Another features are the failure to thrive and recurrent chest infections, and the patient also gets very tired while playing, and shortness of breath is present, and the weight is below third centile and height is below 10th centile, and there is no cyanosis and clubbing. So if there is no cyanosis and clubbing and the murmur is present and there is failure to thrive and there is decreased growth factors, then this is PDA. When there is clubbing and cyanosis present, then it will be tetralogy of failure. But here in this scenario there is no cyanosis, so this is a cyanotic heart disease, that is patent ductus arteriosus. Now the diagnosis is patent ductus arteriosus, and the investigations are X-ray chest, which shows the heart size, pulmonary vascularity, and left atrial and left ventricular size are all directly related to the magnitude of the left to right shunt. Increased pulmonary markings and edema and moderate to large heart size is present. On ECG, it is normal if PDA is small. Left ventricle or biventricular hypertrophy is seen if the left to right shunt is large. On echocardiogram, it is normal if ductus is small and large shunt, left atrial and ventricular enlargement, and ductus can be visualized through suprasternal notch on ECG. The management options are medical management and surgical management. Medically, this PDA can close spontaneously. In preterm infants, indomethacin and ibuprofen is used, and indomethacin is used for 0.2 mg per kg intravenously for 3 doses, 8 to 12 hours apart, and the ductus usually closes after this dose. The surgical treatment is baby not preterm, then surgery is required. The small PDA closure needed to prevent endocarditis, and in large PDA, the closure is needed to prevent the congestive cardiac failure. The ligation and division of the ductus in asymptomatic patient is indicated before 1 year of age, and in pulmonary hypertension, it is not contraindicated. The complications of PDA are that patients with a small PDA may live a normal life with few or no cardiac symptoms, while the spontaneous closure of ductus after infancy is extremely rare, and the main complications are congestive cardiac failure, infective endocarditis, and pulmonary hypertension, that is Eisenmenger syndrome. So this was all about the PDA. We come to know that if there is the machinery murmur present and the patient is below the 10th centile and cyanosis and clubbing are absent and the patient is failure to thrive, then this is PDA. And these are the investigation options, that is X-ray chest, ECG, echocardiogram. On X-ray chest, the heart size and pulmonary vascularity is checked, and there will be increased pulmonary markings and edema and moderate to large heart size on the chest X-ray. In ECG, the left ventricular or biventricular hypertrophy is seen if the left to right shunt is large, and on echocardiogram, the left atrial and ventricle enlargement and ductus can be visualized through suprasternal notch. The management options are both medical and surgical, and the medically indomethacin is given, while surgically it is done for small PDA to prevent the endocarditis, and for large PDA the surgical managements are done to prevent the congestive cardiac failure. Then we have discussed the complications of the PDA, which are congestive cardiac failure, infective endocarditis, and pulmonary hypertension. Now coming towards the next topic, that is ASD, which is Atrial Septal Defect. So the scenario is that there is a 7-year-old female presented to OPD with the history of failure to thrive and recurrent chest infections. Since infancy, she is fully vaccinated and having normal dietary habits. On examination, weight is 16 kg and height is 120, pulse is 80, and chest examination reveals a systolic murmur at left sternal border with splitting first and second heart sound, which are in both phase of respiration. Another scenario is that there is a 7-year-old boy present with exercise intolerance. On examination, he has prominent precordium. He is loud first heart sound and fixed and wide split second heart sound. Patient is otherwise normal. There are also soft systolic murmur at the upper left sternal border. Okay, so in this scenario, the main feature that is represented is that the patient is having splitting heart sound, that is first and second heart sound. And all other features are same of that of the cardiac diseases. So from this feature, that is the splitting heart sound, we will get to know that this is atrial septal defect. So the diagnosis is ASD, and the pathophysiology is that greater right than left ventricular compliance and low pulmonary vascular resistance results in left-right shunt at atrial level, thus increasing flow across tricuspid and pulmonary valve. Right ventricle and pulmonary artery are usually enlarged, and in large defects, the pulmonary blood flow is usually 2 to 4 times systemic blood flow. The investigation options are X-ray chest, which shows increased pulmonary vascular markings, and cardiomegaly. ECG shows partial right bundle branch block, right ventricular hypertrophy, and superior access in primum ASD. Echocardiogram shows right ventricular enlargement. Septum of the 10 often moves in paradoxical fashion, and defect usually can be visualized on two-dimensional studies. The management is medical, surgical. In management, bacterial endocarditis prophylaxis is not necessary in secundum defects but is indicated in primum defects if mitral valve regurgitation is present, and surgery is advised for all symptomatic patients and for asymptomatic patients of 2:1. Time for elective closure is sometime prior to school entry, and closure carried out open heart surgery, and mortality rate from surgery is less than 1%. Different types of ASD are patent foramen OL, ostium secundum defect, ostium primum defect, sinus venosus defect, and coronary sinus defect. The complications are right-sided heart failure, irregular heart beats called arrhythmia, stroke, early death, and high blood pressure in the lung arteries called pulmonary hypertension. So this was all about the atrial septal defect. So we will diagnose the scenario from this feature that there will be splitting heart sounds. Splitting heart sounds. Okay. This is the main clinical feature, and this is the pathophysiology that we have discussed. These are the investigations. On X-ray chest, there will be pulmonary vascular markings and cardiomegaly. On ECG, there will be partial right bundle branch block, right ventricular hypertrophy, and superior excess in primum ASD. On echo, right ventricle enlarged septum often moves in paradoxical fashion, and the management options are medical management, surgical management. The medical management is prophylactic antibiotics are given for endocarditis in case of primum defect, and surgically all symptomatic patients, and for asymptomatic time for active closure sometime prior to school entry and closure carried out open heart surgery is done. Mortality rate is only 1%. These are the different types, that is patent, ostium, primum, ostium secundum, sinus venosus, and coronary sinus. And these are the complications, that is right-sided heart failure, irregular heartbeat, stroke, early death, and high blood pressure in lung arteries. In the next section, we will discuss the congestive cardiac failure and infective endocarditis. Thanks for watching.